I'd like to thank the organising committee for inviting me to come and talk to you about this subject. And I'm going to try and do it from a practical surgical perspective. Obviously, the data will be similar to what we've already heard from the previous two speakers. Conflicts. We've heard this term used in quite a lot of the talk so far this morning. And you can see at the bottom, this actually goes back over 20 years as to what we mean by an R0 resection. As a surgeon, this is what I intend to try and do for my patients, to try and ensure I've removed all possible sites of disease, recognizing, of course, we have our limitations. But the intention is to get the tumor removed, get the lymph node dissection done correctly, and to ensure that the margins are negative. In other words, doing wide margins according to the initial histology. Thanks to the chairman's introduction, of course I'd say this as a surgeon, but we have made some progress learning the lessons the hard way from our colleagues in Japan. There is no doubt that I think in the appropriate patient that we now understand that although the trials have not confirmed the point in statistical terminology, a D2 dissection, extended lymph node dissection, is the appropriate management for most of these patients. But we know, following curative resection, we have problems with recurrent disease, not only locally, despite our surgical attempts, but also with disseminated disease. And therefore, there has to be an additional strategy in the therapeutic approach to these patients. I'm going to go through neo-adjuvant therapies first and then come back to adjuvant and try to give you a practical view on this from the surgical point of view. On the left-hand side, there's the advantages that we would see as a surgeon to undertaking these sorts of therapies. We know that there should be some benefit to enhance our ability to do the R0 resection. The neoadjuvant treatments are better tolerated. There is no doubt about that, and I'll come back to that later on. We do have the fact that we can address nutritional issues that the tumor itself has started to induce in the patient, and we can address those issues up front while we're doing this in concurrence with the neoadjuvant treatment to prepare our patients for surgery. We like to think we can improve survival. The negative, of course, are on the right. Toxicity, which can create some problems, not only in terms of delaying patient getting to treatment, postoperative complications may be affected, there may be a poor response, and we've already heard some reference to that and the way we assess that. And of course, there's the risk, and this is one of the problems, interestingly, we had when we were trying to recruit into MAGIC. Many surgeons in the UK said, I cannot wait 9, 12 weeks before I operate on this patient, they will progress. There's one further disadvantage I have not listed on there, and that's us as surgeons. Surgeon outcome is becoming increasingly a topical issue. In the United Kingdom at the moment, it is possible to get onto the internet and understand my exact outcomes. And surgeons are very wary of having their own data published in the public domain. It's appropriate for transparency, but surgeons are concerned they could end up being risk averse. So if there's a lot of problems with the patients, they may turn patients down from surgery. And I think that's something we need to be aware of. We know from these 3 established studies there is a biological effect, both in terms of T stage and N stage. The neoadjuvant approach reduces tumor volume and allows us to do a more radical resection. All 3 studies have shown exactly the same thing in the treated arms with a reduction in the tumor itself. I'm going to illustrate my talk based upon data we have got from the STO3 trial, which has already been mentioned. This is just to tell you what the trial was, which is the randomization between ECX and bevacizumab. But it's using the data we've gleaned from that to illustrate some of the points from the surgical perspective. Does it delay the time for us to get to undertake surgery? And admittedly, these 2 groups of patients both had ECX, as well as the treated group having bevacizumab, but you can make, I think, a quite reasonable argument to say, actually, there is no real disease progression. These data are very similar to what we had in MAGIC, and as a consequence, it is by conventional methods of assessing the patient at the initial diagnosis, there's a very, very small population who will actually progress and will be found to be inoperable. A lot of discussion about the extent of surgery, and interestingly, in STO3, a quarter of patients were only eligible for an R1 resection. Now, the quality assurance of surgery is something that in surgical circles we debate all the time, and I hope that from the critics trial, when they look at the quality assurance of that using the Mariama index, we will get some more up-to-date information on this. But as you can see, and interestingly, the same came out in critics, the number of lymph nodes that are being removed in current activity, and this trial was done from the 2000s onwards, has significantly improved. So there is something here to suggest that the treatment is actually allowing us to perform our surgery in a more effective way. Toxicity is obviously an issue. You are well aware of this as medical oncologists. But from our point of view, it's the net effect, particularly of the gastrointestinal toxicity, that creates problems. And we often see patients who've completed their chemotherapy come back to clinic. They've had admissions because of problems with diarrhea and vomiting, with mucositis. They've lost considerable amounts of weight, and that can induce an inherent delay in us getting them to surgery. We intend, or we try, to get patients to surgery within 6 weeks of completing their perioperative chemotherapy. This can induce a delay of some weeks to ensure the patient is fit enough, and that not only includes nutritional support, but their general performance status is significantly affected by these approaches. Interestingly, and this is something that we as surgeons are very conscious of, the issue is how we can salvage a patient who's run into problems post-operatively. And the fact that any complication is upwards of 50% within this study, that is actually consistent. There's been a piece of work following in esophageal surgery, a consensus on complications, which is now being taken forward by Don Loney's group, which is clearly showing that in esophagectomy, 60% of patients, that's in good centers, high volume centers, experience complications. So it is not a negligible issue. We don't like taking patients back to theatre. It is jolly difficult to try and take a patient back to theatre and repair and cope with the problem. And so 10% almost of revisional surgery is quite a challenge. And as you can see, there are issues, particularly with regard to sepsis, and that is the main problem, possibly relating to anastomotic failure, but possibly also relating to other reasons for intraoperative infection, post-operative infection that we, as the surgical group, have to cope with in their post-operative management. Fortunately, our perioperative mortality has significantly improved, and I think that's a combination of the multidisciplinary approach to patients. However, we don't like this. Anastomotic leak rate in the National Esophagogastric Cancer Audit in the UK runs at about 6% for esophagogastric surgery. The net effect, then, we had this announced with information from the data monitoring group from STO3 that there was a significant increase in anastomotic leaks in those patients receiving bevacizumab who had esophagogastrectomy, and the associated mortality was not a good thing from the surgical point of view. We were not sure why. We still don't understand why, because interestingly, we did not see this in patients having a total gastrectomy, where the esophagoduodenal anastomosis is technically more challenging. So these are issues that we have to face, and it has to be borne in mind in the multidisciplinary approach to the patients. Let's move on to adjuvant. We've heard a fair bit about this, and I'm afraid I will repeat some of the slides. The advantages of giving adjuvant is that you do then know what the stage of the disease is. You know how to tailor your treatment. In theory, you've got a lower tumour volume. The tumour cells may well be more responsive to adjuvant therapies. But it may well be delayed because of the complications I've talked about. It may well have an effect from the point of view of tolerance for the treatment that you're planning. And again, there's the toxicity issue. And it can be extremely difficult with regard to treatment planning. As you've already seen from the chairman's slide earlier in the esophageal talk, you can end up with a colossal radiation field, which is prohibitive to treat. We've heard about this slide, we've seen it, and it's well known. And it does demonstrate that there is a potential role for chemoradiotherapy. From the surgical perspective, our problem is that the surgery was not standardized, and the criticism has always been that the chemoradiotherapy post-operatively made up for less than what would be accepted now as appropriate surgery. And I think this has to be borne in mind. But interestingly, what I think critics is telling us whether surgery has been more standardized. I do accept the point with regard to what's happening with the ARTIST trials, but what's happening in Europe from regard to this approach is that, in fact, chemoradiotherapy across the whole piece of patients, whole sample of patients, is not adding anything to what would be considered pretty optimal surgery in current parlance. We remain to see what happens if the subgroup analysis shows with regard to lymph node positive patients. And I think this is the key to the issue with regard to adjuvant from our point of view. Across all of the trials, be they post-operative chemotherapy, post-operative chemoradiotherapy, it is extremely difficult to get the patient to complete the planned post-operative therapy in what the protocols have expressed should be done. And I think this is the key to the problem we face. What we are doing to patients is a very major physiological insult. We have got better, as I've already shown you, and I'm going to show you a little bit more information in a moment, but it still means that we are struggling to get the post-operative phase of treatment into all comers, and it may well we've got to look a bit more selectively. And the other challenge, I think, is this one. We've seen this slide, but the point on this slide is the surgery-only arm. Overall survival at 5 years is 70%. That is something that we really would love to be able to do in surgery only in the West. There's possibly some hints that we might be making some progress. On the left-hand side is the survival curve from MAGIC, and the right-hand side from STO3. And you've got the median survival. An improvement, probably multifactorial, better selection, better MDT discussion, and I would hazard to put to you, better surgery. We are looking at the surgery outcomes in STO3 and bring that forward in due course. But in our own experience, in our own institution over the last 10 years, with appropriate changes which have been of multidisciplinary nature, we have demonstrated a significant improvement in our survival for patients treated in one institution. And I think that's a reflection of some of the changes that have occurred in the United Kingdom, not the least of which as being the centralisation of surgery. So my summary, preoperative chemotherapy, better compliance, better response evaluation, better tolerated, and more R0 resections. Post-operative therapy, I think we have to consider. I don't think it can be dismissed. I know there are some limitations, but I think we have to be much more aware of what the subgroups or what the specific areas need to be addressed to consider the addition of therapy post-operatively, which will not be easy. And I would also make the argument for optimal surgery in high-volume centres. And really to leave you with the right-hand comment from Takeshi Sano, which I think is the direction of travel I feel we need to begin to think. You have to select which treatments you need based upon the varying parameters with which the patient presents to arrange what you're going to do for that individual patient, bearing in mind the data we have available to give them the best possible outcome. Thank you very much.